finasteride or dutasteride should not be started in male patients who are not sexually mature. If the androgenic alopecia starts at a very, very early age, or the stem cell-based treatments, I think there's one important thing to say.
I shifted one of them to dutasteride. The sexual dysfunction disappeared, while the other... My name is Dr. Val Cua from the Philippines. I am the outgoing fellow of Professor Rudnicka here in Warsaw. So today, we have a special treat for everyone as we will be discussing some of the common questions dermatologists ask us regarding the management of androgenetic alopecia. As you all know, Professor Rudnicka is a world-renowned trichologist with a lot of publications in hair disorders and even the Atlas of Trichoscopy. So without further ado, shall we start, Professor?
Yes, sure, but we need to say you are a young dermatologist. Your name is Val Constantine Cua.
Yes, Professor.
And it's a great pleasure to have you here in our department.
Thank you so much for having me. So, regarding the management of male androgenetic alopecia, there's have been a debate whether finasteride or dutasteride should be started because of their different efficacy. What's your opinion regarding this?
Both of these drugs are more effective in patients who are younger, so we should rather start early. However, in my practice, I always start with finasteride, and I always start with a dose of 1 milligram. The reason for this being is that this is the only dose and the only treatment that is approved for male androgenic alopecia. All other treatments and all other doses, so either a higher dose of finasteride or dutasteride, they are both off-label. So I have a preference to start with the on-label treatment, and then my second choice would be the other options. It also requires a longer discussion with the patient. We also need to remember that dutasteride has a much longer half-life. So always it's a decision between efficacy, safety, and the rules, the approval.
Do you know, Professor, like how long is the washout period when you start patients on dutasteride versus finasteride?
Yes, I follow the guidelines of the FDA for men who want to be blood donors. And the FDA is saying that for finasteride, it's 1 month, and for dutasteride, it's 6 months. And also, I follow this rule regarding my patients.
Now, regarding, Professor, on how early you start, you mentioned that you wanted to start early. And sometimes we do see adolescent patients that already have signs of androgenetic alopecia. So is there an age limit on how aggressive or how early you start treatment?
Yes, you are completely right. The number of patients who start having androgenetic alopecia in a very early age, as teenagers or even as small children, is increasing. We observe this in our practice. And the general rule is if the androgenic alopecia starts at a very, very early age, meaning before the age of 6 years, then it is necessary to perform an endocrinological checkup because this may be the effect of a systemic endocrinological problem. However, if there is no endocrinology problem or the child is a little bit older, then of course we start treatment. However, one important thing to remember is that finasteride or dutasteride should not be started in male patients who are not sexually mature because 5-alpha reductase inhibitors will decrease the sexual maturation of the men. So the age is usually 17 up to 21 years. Sometimes I ask an andrologist for his approval. I know that some of my colleagues follow the rule of adulthood. Adulthood in many of the countries is 18 years. I don't know how it is in your country. It's also 18 years old.
Everyone in my country usually starts at 18 because they're very conservative. They will always start with minoxidil. And that's the safest, the topical minoxidil rather. And I think we're all just trying to play safe since we don't have studies on the younger populations.
Exactly. And this is even more the problem in girls because we have no studies whatsoever in women who are younger. than 18 years old or younger than adults. So maybe from the biological point of view, we could start 5-alpha reductase inhibitors in younger girls, but there are no medical data. And when there are no medical data, it would be an experiment.
How much can medication actually delay a patient's risk for having hair transplant?
This is a really tough question. I think that patients who start treatment at the early phase of androgenic alopecia, and early phase is really the clue, because if it's an advanced androgenic alopecia, there's not much what we can do. If we start very early and the patient is seeing the dermatologist in regular intervals, I think probably some of the patients may avoid the development of severe androgenic alopecia. Not everyone will decide to have a hair transplant, but I think among the people who would decide to have a hair transplant, the number is probably lower with the ones who get regular treatment. And also, just to mention, we both know that a hair transplant is not a therapeutic solution. It's a solution in terms of replacing the hair that was miniaturized with terminal hairs taken from the occipital area. However, it does not treat the disease. So we still need to continue the treatment of androgenic alopecia in addition to the hair transplant.
In this regard, that we all know that androgenetic alopecia is a progressive type of hair disorder, does this mean that patients will be maintained forever or in their whole lifetime on medication to prevent progression?
I will ask you in a moment about your practice. I would say no, and there are different opinions on this. My approach is that usually I go on with the treatment for approximately 1 year or 2 years, and then I try to discontinue, because I think that the activity of androgenic alopecia is going in waves. And when there is a wave of higher activity, then I do make sure that the patient receives proper treatment. However, when there is no disease activity and no progression despite no treatment, then I just observe. So I see the patient every half a year after discontinuation of the treatment. If there are any signs of progression of the disease, we start the treatment again. But this is my general rule. With some patients we discuss, we want to go on with the treatment for 3 or 5 years. Some patients are afraid to discontinue, and they go on for many years. What is your approach?
I agree with you that it's actually a discussion between the patient regarding the maintenance of the medication. But I agree, I am actually to actually keep them on the medication. I believe that the activity of androgens do fluctuate. And I think I agree that at some point we may offer the option to discontinue unless the patient is afraid to actually stop the medication.
So there is no rule. When we say lifelong, it's not a rule. And when we say 3 years, it's also not a rule. It is really very variable.
Regarding the patients on finasteride or dutasteride, we all know that the common adverse effect would be sexual dysfunction. In your experience, Professor, have you encountered a lot of patients complain of sexual dysfunction? And what do you usually advise? Do you continue or discontinue medication?
I see it extremely rare. Really, when we look at the numbers, the numbers show that many patients with androgenic alopecia with no treatment may have sexual dysfunctions, including decreased libido, which is most common. The prevalence is approximately 3 to 6% of patients with no treatment. And now there is an increase of the risk of sexual dysfunction after finasteride and dutasteride. I see 3 possible reasons for this. First is the true effect of the drug by a mechanism which is not understood. Second is because we know that sexual dysfunction in a major part is influenced by psychological factors. And because we know that there may be such an effect, the fear may increase the risk of the prevalence of these adverse events. And then the third possibility is that patients are more aware of the problem and they're more looking for the possible problem, which they would not observe maybe if they would not be aware of this. And now, why I am saying this? Because it was observed that once the sexual dysfunction part in the leaflet was enlarged, it is in more detail, it turned out that from this year on, when the leaflet was changed, the number of cases of sexual dysfunction has significantly increased. But yes, it's possible. It's not common, and I would even say it's very rare. And when you ask, would I advise? I talk with the patient, and I must say my patients, and also this is the same as the literature shows, that most patients will not stop finasteride even though they experience some sexual adverse events, because the importance of the hair for them is bigger than the importance of transient problems with sexual health.
I actually agree. And in my practice, I think I've only had one or two patients that complain about sexual dysfunction and finasteride. And what's interesting actually is that when I shifted one of them to dutasteride, the sexual dysfunction disappeared, while the other noted that there was still persistent and he opted to stop the medication. And it should be an understanding between the patient that when we hold the medication, the possibility of progression starts.
Exactly, this is the case.
Now, let's talk about female androgenetic alopecia. We see a lot of literatures right now that we can start spironolactone or even the 5-alpha reductase inhibitors, finasteride and dutasteride for females. Do we actually start both of them together, or can we just choose one? What do you think, Professor?
Well, regarding spironolactone, it's a very old drug, but the literature is quite new. And yes, I think there is some efficacy of spironolactone. However, most of the experts underline that it should not be used in monotherapy unless we need to do it because of some individual situations in the patient. Regarding spironolactone, the efficacy may be visible in some patients, and the problem is that there's no clear methodology of how to apply the treatment. The dose ranges from 25 milligrams and even less up to 200 milligrams per day. So the adverse events are not significant. There's also a possibility of using the topical spironolactone either in the form of a gel or in the form of a solution. However, we always have to keep in mind that every treatment, whatever we put topically on the scalp, because of the microvascular presence and because of the hair follicles, the penetration through the skin is really very high. So the systemic effect is visible regardless what we use. So in the context of spironolactone, we can use it topically. However, it will also have a systemic effect. When asking monotherapy or combined therapy, I would go for combined therapy.
So do this medication have a different mechanism action that you think combination actually will benefit more the patient?
They have a different mechanism of action. They're both anti-androgens. However, spironolactone has a systemic anti-androgen effect. Finasteride and dutasteride have only a local anti-androgenic effect, which is limited to the hair follicles and also to the prostate almost exclusively. This makes it possible to apply finasteride and dutasteride in men. In the case of spironolactone, this is a systemic effect. In most situations, we should not use spironolactone in men.
Do you think that topical finasteride is also as efficacious as the systemic finasteride when it comes to the female? What do you think about this?
This is really a problem that nobody can solve because there were no head-to-head studies. My impression is that systemic treatment is always more effective compared to the topical treatment, most importantly because systemic treatment is really very, very clear-cut. We know the dose, we know how often it is taken, so it is a more clear situation. In topical, it depends. When the patient has no hair, it will be a different effect compared to a patient who has a lot of hair and the hair is long and part of the product is on the hair. It's never exactly the same amount of the topical treatment on the same area of the scalp. So because it is really difficult to standardize, in my opinion, I would go for systemic.
Now let's talk about minoxidil. We have currently topical minoxidil, and in some countries the oral minoxidil is available. Do you recommend that we actually test each patient for their sulfotransferase activity before prescribing the topical minoxidil?
Well, my answer is no. We know that sulfotransferase is converting the non-active or the almost non-active form of minoxidil into the active form. However, only few laboratories are doing the test. It is not very standardized. And we really do not have clear data to show that if we really measure the amount, what does it mean? because the data which are available, they're only the data for vasodilatation. And we know that minoxidil has a multiplicity of activities and mechanism of action. Most importantly, it is vasodilating for the hair follicles, but also it has an modulatory effect. It has some minor anti-androgenic effect. So we really do not know what the sulfatransfer is doing, and because of its low availability, I do not recommend doing this in everyday practice.
Since not everybody has the access for oral minoxidil, in your opinion, is topical minoxidil as efficacious as the oral version?
There are some studies which try to convince us that this is the same. However, as mentioned, with the systemic treatment, we always have a clear-cut situation with a clear dose in clear intervals. With systemic, again, we don't know what will be the amount put on the scalp. What is the specificity of the scalp? Are there some injuries or some scratches which will increase the penetration? Are there many hairs which will absorb the product so it will not be available for the hair follicles? So I would say, in my opinion, my preference would be systemic, also with the topical minoxidil.
How was your experience with the side effects when you gave the systemic treatment? Are there a lot? Because I think that's also one of the concerns, knowing that minoxidil was initially created for patients with hypertension.
Yes, it's true. And the higher the dose, the bigger the problem. And with minoxidil, it has been shown that the well-tolerated dose for men with no or almost no risk of significant adverse events is approximately 3 milligrams per day. For women, it's a little bit above 1 milligram per day. So the tolerance is higher with the men. And regarding adverse events, I do not see them very often. The most common adverse event, according to the literature, is the extra hair, especially in women, which is undesired. However, many women prefer to keep the undesired hair and go on with minoxidil. Some of them decide to discontinue, but for me, a solution is to decrease the dose. And in many cases, decreasing the dose helps with the adverse events. The second adverse event I have seen in some cases is the possibility of vertigo, of dizziness. And this usually happens approximately 1 to 2 hours after the pill has been taken. So I advise the patients to take the pill in the evening, for the reason because if they do it in the morning and they ride the bicycle to school or to the work and they get some vertigo, we are in trouble. However, also if this adverse event occurs, then I also decrease the dose. And the third adverse event which may happen is the leg edema. And my experience is that I see leg edema only in patients who had prior leg edema. It is increasing with minoxidil. I have never seen leg edema which would develop de novo with minoxidil. What doesn't mean that it cannot happen, but it's quite rare. Headache was described in literature. I have not seen this very often, and some other adverse events which are uncommon.
I agree. Also, in my practice, I think hypertrichosis is the one that's most commonly seen, especially in my female patient. What's your opinion on the dose for the female? Because they say that start the lowest so that you also have the less side effect, like 0.5 milligram. Does it work, or is 1 milligram a better dose?
This is a difficult question. I make the decision about the dose on a very individual basis. If it's a woman who is, let's say, average sized between 55 and 75 kilogram, in general healthy, with no other treatments that can be interacting with minoxidil, I would usually start with 1 milligram. However, in women who are thinner, I start with a lower dose. If the woman, talking about woman, if the woman has some cardiac problems, I advise to first see the cardiologist and to receive an acceptance for minoxidil, even though I know from literature and from life that there are no significant cardiac adverse events. I prefer that the patient is seeing the cardiologist. If this is an elderly person, then also my approach will be different and I would start with a low dose. So depending on the very individual situation, I think we need to make the decision individually.
Now, speaking about old person, just a segue from the management, there's an interesting discussion regarding senescent alopecia or the physiologic alopecia. And commonly we get female patients actually complaining this. How do we differentiate this from a female with androgenetic alopecia in her older or elderly years?
This is a very important question because to be effective in treatment, we need to have the right diagnosis. Because, of course, 5-alpha reductase inhibitors will not be effective in physiologic alopecia, what was earlier called senescent alopecia or senile alopecia, even earlier. Also, if I can mention, there is another disease which looks very like androgenetic alopecia. It's fibrosing alopecia and pattern distribution. Very similar, but here the treatment needs to be totally different. But concerning senile alopecia or physiologic alopecia, what is very characteristic that unlike androgenetic alopecia, there will be no hair shaft thickness heterogeneity in trichoscopy. So this is the major difference because in both diseases we will see thin hair. In both diseases we will see a decreased number of hairs. So here the differential diagnosis is really difficult, and without trichoscopy we are unable to do it.
We've mentioned about fibrosing alopecia with a pattern distribution of FAPD. How common is it now in your clinical practice to see this type of scarring alopecia? Because we might be diagnosing physiologic or AGA in a female patient, but it's actually a different thing. So what's your clue and advice for us regarding this FAPD?
Well, trichoscopy. With trichoscopy in fibrosing alopecia and pattern distribution, we will see features of scaling alopecia, sometimes even some perifollicular scaling similar to lichen planopilaris. As mentioned, there will be no significant, there may be some hair shaft thickness heterogeneity, but it will be not that significant. And also the number of vellus hairs will be significantly decreased as compared to androgenetic alopecia. And yes, we see these cases, and I think we need to be aware about the possibility. So yes, the number is increasing. Whether it is increasing because the number of patients is increasing, or is it increasing because we see more, it's really difficult to say.
Is there like a particular age that we actually might want to start suspecting for FAPD?
Most of my patients with fibrosing alopecia and pattern distribution are at the age of approximately 50 to 70.
Women. So mostly on the elderly age, like late 50, early 50s. Right?
Come on, 50 is not elderly.
Now, with this, to diagnose this, do we even need to do a biopsy? Because in my clinical practice, and as I teach also my residents, you don't actually have to do biopsy on all type of hair disorders. So when do you actually advise to do a scalp biopsy?
I always perform a scalp biopsy when I don't know the diagnosis on the basis of clinical evaluation and trichoscopy. And now we also perform LCOCT, which makes life a little bit easier. However, also performing a biopsy, we need to have a tight cooperation with the dermatopathologist who has the knowledge about hair diseases.
Do you still follow the guideline that at least 2 specimens to be submitted, or it depends on the disease that you're thinking?
No, I even heard about the method to take 6 biopsies because we have a better sample. No, we are taking 1 biopsy. We are carefully choosing the place for the biopsy with a trichoscopy guided biopsy, and 1 4-millimeter biopsy is usually very sufficient.
Do you ask them to do a horizontal or a vertical cut for this?
I write what I expect clinically, and the dermatologist is making the decision how to manage this.
That makes life easier for us.
Yes, definitely.
All right. Now let's go now to the adjunct treatments that are on the rise regarding androgenetic alopecia. So let me start with the component I recently heard, stemoxidine. So I see a lot of this being distributed online in different formats.
Well, regarding the effect of stemoxidine and in general the product, it's a product which is based on plant extracts. It has slightly a similar way of action as minoxidil by the way that it inhibits the PhD. However, as mentioned, minoxidil has a very wide range of mechanisms of action, and here we know about just a small part of it. There are no large studies to really tell about the efficacy. Some of patients are quite happy. Maybe I'll also mention this is a top product. either in the form of shampoo or some other topical product, serum. Anyhow, I think there may be a future for the product, but I would wait for more literature. But if my patient is using the product, it's fine for me. I do not discourage, definitely.
Now, what about mesotherapy such as PRP, exosomes, and Regenera, or the process of getting a biopsy to use the stem cells for injection on the scalp? What are your thoughts on this?
Yeah, thank you for mentioning one important thing. Mesotherapy is not a method of treatment. Mesotherapy is a way of delivering a drug to the scalp or to the dermis. So when a patient is saying, "Oh, I had mesotherapy," I ask, what was the product? Because mesotherapy is just injections. So I will start with PRP, which is most common. There is a lot of literature. Unfortunately, there is no standardization. So when I can say from my perspective, I never use it in monotherapy. I always use it as an add-on to therapy, which is already going on. I think there may be some efficacy. However, still the problem is we are waiting for standardization because every doctor is performing it according to a different protocol. Some are performing this every week, some every 6 weeks, some every 4 weeks, some every 8 weeks, some every 3 months. And then the products are different, the ways of preparation are different. I think really here we are waiting for standardization. The stem cell or the cellular-based treatments. When talking about the cellular-based treatments or the stem cell-based treatments, I think there's one important thing to say. Because as doctors, we expect that a stem cell-based treatment would generate new hair follicles. And we need to be clear about one fact. Currently, there is no way to generate new hair follicles. Because if this would be the case, we would have the treatment for cicatricial alopecia. So here again, it's a problem of lacking literature. And I left the exosomes for the final part of this question because I think that exosomes are really a future in medicine. These are the small pericellular vesicles. They may be used as a delivery system to the cells, but also by themselves. They contain proteins and some genetic material which can stimulate many biological processes, and it may have some anti-inflammatory activity. So I think whether it will be the case in androgenetic alopecia, for me, it's a little bit too early to say. I think the results of the studies which are available are really promising. However, let's see. But in medicine in general, I think exosomes are really the future, and exosomes will be a word that will be known by every student of medicine in the future.
We just talk about the microneedling. The concept regarding that I've read about is that whenever you do microneedling on the scalp, you actually cause some injury, and that injury actually stimulates generation of proteins that actually heal the wound, and that can actually help with the growth of new hair. Do you think it's the same as PRP, where you're injecting and causing trauma?
I think we're talking about two aspects of mesotherapy or microneedling. Because when performing mesotherapy, you also make an injury. But also there is a method to only make the injury and not use the drug. A third method is to make the injury and then use something topical. Now, the thought is, as you mentioned, that if we cause very small injury, these are very small needles, then the body will react with a vasodilatation. And we want vasodilatation under androgenetic alopecia to stimulate the hair follicle, and usually the effect is the prolongation of the anagen phase of the hair cycle. However, when I was talking to our dermatopathologist, she's saying that she's seeing these scars from microneedling in histology. And she's saying, well, how many times can you perform this without causing hair loss because of scars which are caused by microneedling? So I think we should be aware that as a temporary solution, we can try this, but it's not a solution to repeat for a long time.
I guess that's all the questions we have gathered. I hope these were able to answer the common mysteries regarding the management of androgenetic alopecia. Thank you so much for your time, Professor.
Thanks a lot, and thank you for watching. Thank you.